Good morning, everyone. As usual, next Monday has come and we are here to discuss very important topic, dementia. And today's topic will be discussed by one of our residents, a senior resident from Tata Memorial Hospital, Prarthna. So I will request Dr. Joyita to introduce Prarthna and then we can start. And you can all send your question and answer to chat box. Arun will sort it out and then we will discuss all the questions and answers afterwards. Okay, go ahead. Dr. Chaita, please go ahead.
Hello, good morning. Thank you, Sushma ma'am. Good morning, everyone. Archana, could I have you put up the, yeah, hi. So it's my pleasure to introduce Dr. Prarthna Jayseelan to you. You can see from the slide that she has completed her MD in palliative medicine this year from Tata Memorial Hospital, and she's currently working as senior resident in Department of Palliative Medicine at DMH. You can understand from the slide itself how very modest she is, because she's just written those 3 lines. So I feel that it is important for all of you to know about her. Dr. Prarthna is an extremely dedicated, sincere, hardworking, punctual, and reliable clinician. She's one of the first ones in the OPD and does not move out much except for lunch till the OPD finishes. She has a great clinical acumen. She is interested in research and has completed a few projects in the department and her own thesis. And she's part of an international collaborative study. So I am very proud that she has been, and she is my student. And she's extremely approachable to her juniors and works very well as a team member. And we all learn from her every day. And so we are actually privileged to listen to her on this topic on advanced dementia and palliative care aspects related to that. So welcome, Dr. Prarthna, and over to you for your talk.
Thank you, ma'am, for this introduction. I will be sharing my screen now. Is my screen visible?
Yes.
Okay.
Yes, it is visible.
Yes,
Prarthna.
okay, ma'am.
Slide show kar do bas isko.
Yes, ma'am. Yes. Good morning to everyone present here. I would firstly like to thank the IAPC Academy for giving me this opportunity to present a lecture as a part of the neurology series. So the topic given to me was advanced dementia, but I'll be covering some general aspects of dementia too. So the first thing that comes into our mind when we hear the word dementia is probably memory loss, but it's not just that. A lot of other clinical features also associated with it. And we have seen someone or the other in our family or someone we know losing themselves, losing their personalities to this disease. So hence I feel it's very important to know, have a general picture about the disease. So these are the topics I will be covering today as a part of dementia. So according to the DSM-5 definition, dementia is dementia may be used as an umbrella term for most of the neurological conditions, and in which the major symptom is deterioration in cognitive function, and that is beyond usual consequences of biological aging. So the DSM-5 has a category of neurocognitive disorders, which is further divided into major and minor neurocognitive disorder, and dementia comes under the major neurocognitive disorders because it fulfills the following criteria. It shows significant cognitive decline. there is impairment which is acquired, and it represents a significant decline from a previous level of functioning. The cognitive deficits must interfere with the independence in everyday activities. The disturbances are not exclusively during the course of delirium, and the disturbances are not better accounted by any other mental disorder like major depressive disorder or schizophrenia. So the difference between the major neurocognitive disorder and minor neurocognitive disorder is that the cognitive deficits will not interfere in the independence of everyday activities in minor neurocognitive disorder. So you can say it's minor cognitive disorders lies in between normal aging process and major neurocognitive disorder like depression. So as I said, there's cognitive decline, and we need to know there are 6 cognitive domains, and according to the DSM criteria, in one or more should be affected in dementia. The first cognitive domain is complex attention, which involves sustained attention, divided attention, and selective attention. So here the patient will show warning signs like difficulty in environments with multiple stimulation, like a living room which has a TV or and a conversation going on at the same time. The second domain is executive abilities. So it involves planning, decision making, and responding to feedback and working memory. So here the patient will show warning signs as difficulties and in performing, and he'll have to rely more on others for instrumental activities of daily living. There will also be problem in abstract thinking and poor or decreased judgment. The third domain is learning and memory. So it involves all 3 aspects: immediate, recent, and long-term memory. Here the patient will find it difficult in maintaining a conversation and losing track of words, and he will require frequent reminders. The fourth domain is language. So it involves all the subdomains of language, that is naming, fluency, grammar, syntax, and comprehension. Here the patient will have difficulties in expressive or receptive language, and they may not even recall names of closer friends and family. The fifth domain is perceptual motor and visual perception and praxis. So praxis is a loss of learned motor movements in the absence of any primary motor deficits. So here, even small tasks like picking up a phone or handwriting, the patient will show warning signs of difficulty in performing simple tasks. Then the last domain is social cognition, and which is a very important part, as a lot of behavioral changes will be observed in this domain. The patient may become withdrawn and isolated, and may show abnormal behavior in society. So after knowing the definition of dementia, I would like to focus on, let you all know about the burden of dementia. So according to the WHO, around worldwide 55 million have dementia, and this number is only going to rise by 2050. That's expected to go up to 139 million. So at a time, every 3 seconds, someone in the world is developing dementia. So that's a very, very huge number. And in our country, there have been many epidemiological studies, and the rate of people developing dementia over 65 years is around 2 to 35 per 1,000. But a very recent systematic review and meta-analysis published says that there were around 20 per 1,000 population with dementia, and this prevalence, it is more in age groups above 75, and however the rates were similar for both males and females, as well as rural and urban population. So now, since dementia is, I mentioned earlier, is an umbrella term, but there are different types of dementia which we should know a little about, because the clinical features are a little different. Alzheimer's disease is the most common type of dementia. It's prevalent around 60 to 80%. It is due to plaques and tangles buildup. This has very prominent memory loss right from in the earlier stages, and it only keeps getting worse as the patient grows older. The second most common type is the vascular dementia. The prevalence is around 20%. It's usually mostly after a massive stroke. So your memory loss is not so prominent. There will be features of confusion and difficulty planning earlier. And symptoms may get better in time if there is improvement in the ischemia. And sometimes may get worse if the underlying risk factors are not corrected and patient keeps getting recurrent strokes. The third type is the Parkinson's dementia associated with Parkinson's disease. So this is like, it speaks for itself. There will be features of Parkinson's along with dementia. And I think we've had a topic last week, which was describing dementia and Parkinson's disease. The fourth type is dementia, Lewy body dementia. The prevalence is around 10 to 15%. There is also, there is higher risk of developing Parkinson's disease. And in the earlier stages, there'll be difficulty concentrating and planning. Visual hallucinations is very common in this type of dementia. And also the symptoms keep progressing with time. Frontotemporal dementia is a very rare type of dementia. Its prevalence less than 2%. It is seen more in the younger population. And earlier, there will be behavior and personality changes and language problems. The patient might show some exhibit impulsive and inappropriate behavior. So this is actually the most very distressing for caregivers to see their patients go through this type of dementia. So after we know the types of dementia, I just want to highlight that these the characteristics of dementia are more distinguishable during early stages. As the disease progresses, the features overlap a lot. So we must also know how to evaluate dementia. So the most important thing is the patient's history, which is usually given by the person living with the patient, because they are the ones who notice changes in memory and personality in the patient. It's also important to include the drug history while evaluating these patients, because geriatric population is they may be on antipsychotics, anticholinergic drugs, or steroids, or even some features of dementia can be even seen on alcohol withdrawal. And the most integral part of evaluation is the cognitive assessment. So I'll be going a little bit in detail. So there are screening tests available like MMSE and MOCA test, which they are more standard and valid tools which can be done at bedside and takes around 15 minutes. Then the second type of cognitive assessment can be extended mental status examination, which can be done at bedside, 30 to 60 minutes, and there are a battery of tests. So these tests the problem is that it's not standardized and it will vary from different neurological settings. The third type is the formal neuropsychological testing, which will take several hours and will require multiple sessions. It doesn't have to be done in a single session. Most important is that you have to make the patient very comfortable and to elicit these tests and build a rapport with them. So the first, there are different domains in this neuropsychological testing. We'll just go a little brush on each of them. Level of consciousness, we have to see if the patient is alert, attentive, sleepy, or unresponsive while we are communicating with them. The attention and concentration, there are many tests available like the digit span forward and backward test, serial subtraction, or spelling a word backwards. The memory, or like I mentioned, immediate, recent, and remote memory, everything has to be tested. So there are various tests like the same digit span forward, backward, for immediate. Recent memory can be judged by asking someone to repeat 3 or 5 words we had mentioned 5 to 10 minutes earlier, and a patient should be able to repeat all 3 in if they have normal cognition. Remote memory can be assessed by asking them to name presidents or in reverse order, such like that. Language, again, all the domains have to be tested: the fluency, content, repetition, naming, and comprehension. So the visual spatial perception is usually tested by asking a patient to copy or draw some tasks assigned, like a 3-dimensional cube or overlapping pentagons, or also a clock drawing, which is most commonly done. They have to place their hands at the time mentioned to them. Praxis can be judged by asking a patient to be giving him an object and asking them how they would use it or show the action, and it can also be assessed by asking them to do some coordinated tasks and see how easily they perform it. Calculations, again, their serial subtraction is mostly done to assess calculation. Executive function has multiple tests under it, so you are also there is a trail making test where the alphabets and numbers are jumbled, and someone has to pass a trail through all the alphabets, and a trail through in order, and a trail through all the numbers in order. Or sometimes you can make it more complicated by passing an alphabet and a number trail through them in order. And then there are other motor programming can be assessed by the go and no go test and fist edge palm test. And also abstract thinking is judged by giving them some phrases and asking them to interpret, or giving them some situations and asking them what would they do in such a situation. Mood and thought content is very important aspect which needs to be assessed, because most of them might be having, a geriatric population may be having some underlying mood disorder which is not diagnosed earlier. So they need to be usual scores like Beck depression inventory and geriatric depression scale, or a neuropsychiatric inventory can be administered to assess for any mood disorder, especially depression. So with that, after this, there are also some lab investigations which need to be done at the earlier stages to just rule out any reversible causes of dementia. So they have mostly vitamin B12 deficiency is a classic, it's one of the most reversible causes in their population. The blood counts like CBC needs to be assessed if you are suspecting sepsis. Electrolyte disturbances, again, very common in later stages, especially hyponatremia, and also thyroid levels because they are very susceptible to hypothyroidism. Then neuroimaging, CT scan, a non-contrast CT scan and MRI is recommended in the earlier stages, not in the later stages. But between these two, an MRI scan is advised. But we would prefer a non-contrast CT in certain situations where a person might feel too claustrophobic, or if their patient has pacemakers or implants and you have to do a CT. So there are certain changes which are seen with type. There will be cerebral atrophy, hippocampal atrophy, and ventriculomegaly and microhemorrhages over on the scans. So after the evaluation, it's important for us to know how to grade the severity of the symptoms so that we can plan a management and know where in the disease course the patient is. So this is a very old type of staging, which is just divides symptoms based on the severity in 3 domains, that is cognitive, functional, and mood. But we don't usually use this now. The most common staging system we use is the FAST staging, that is a functional assessment scale. But this is also just actually specific only for the Alzheimer's phenotype. There are no specific staging systems for the other types of dementia. And usually it's always the FAST scoring which is done even for them. So as that's divided into 7 stages, and the 6th and 7th stage are further subdivided into So the 6th, 7th stage are the more advanced stages. And especially the 7th stage is very important. Once patient reaches this, then they are more eligible for hospice, and it's important phase to start prognosticating and understanding what to start prognosticating and try to counsel the caregivers regarding that the prognosis is poor at this stage. So I'll just read through. In the 7th stage, the patient is he can't speak, so that he'll be able to speak just less than 6 intelligible different words. The speech ability is limited to a use of single intelligible word in an average day or in the course of an intensive interview. 7C is ambulatory ability is lost. 7D, he cannot sit up without assistance. 7E, he loses the ability to smile, and 7F is loss of ability to hold up head independently. The global deterioration scale is also a scale which divides the stages of dementia into 7 stages and based on the cognitive decline. But still, overall, generally, the FAST staging is only used. So this, and also we have the clinical dementia rating scale, which has 6 domains, and the scale is from 0 to 3. We can read this up later. Also not routinely used now, earlier present. So this is a comparison of all the staging groups with MMSE and then approximately their survival. So we can see the advanced stages is the 6th and 7th stage. And this stages, it occurs almost 10 to 19 years after this. This period is 10 to 19 years after the diagnosis of dementia. So you can understand that this is a very, very long, arduous course. So at this time, also when the severity develops, the cognition is very poor. So you can see the MMC scores are minimal or are almost equal to 0. Even the psychometric testings are impaired. So why, in the next part I would like to go through is the symptom assessment. So why is this very important? It's because it's to help them plan the management and perform their daily activities to the best of their ability. And as I mentioned earlier, cognitive status is a very important part of symptom assessment. So we have to use a reliable and valid instrument like the MMSE. Other medical conditions need to be also assessed. Behavioral problems, psychotic symptoms or depression has to be assessed. We also have to, at the earliest time possible, assess the patient's decision-making capacity and whether a surrogate has been identified. You have to identify their caregiver needs, and it should be routinely assessed. And we also should assess the family's culture, values, and their language and literacy level during the course and of the disease. So management of symptoms requires a multidisciplinary team in which a neurologist, psychiatrist, a geriatrician, a palliative care physician, a general physician, a specialist nurse, a rehabilitation expert, nutritionist, and a social worker caretaker have to be involved. So on the right side, there's a model describing the integration of neurology, rehabilitation, and palliative care for effective symptom control in long-term neurological conditions. Let's go ahead with each symptom. The most important symptom is a cognitive impairment, which is a core feature of dementia. And there are a lot of psychological methods which have been used, like reality orientation, reminiscence therapy, and validation therapy. But there is very little evidence to support its use in clinical practice. Non-pharmacological management, like keeping reminders and notes and alarms, helps in the earlier stages. And pharmacotherapy there are two main classes of drugs, that is a cholinesterase inhibitors like donazepam, rivastigmine, and galantamine. So these drugs, the mechanisms that increase acetylcholine, and in patients with dementia, it's postulated that the symptoms of dementia, of cognitive impairment, are due to low acetylcholine levels. The second class of drugs use an NMDA receptor antagonist like memantine, so it prevents damage to neurons caused by glutamate. So just that I would like to add that there is no known cure for dementia, especially the cognitive symptoms. So you need to have both pharmacology and non-pharmacology measures, as well as lifestyle changes. And all these drugs are not suitable for all types of dementia. They are not useful in the frontotemporal type of dementia. And vascular dementia, the management of it also requires management of underlying condition causing the vascular event. And so hence these drugs only help in slowing the progression, so they work only in the early stages of dementia. The next symptoms are the behavioral and psychological symptoms of dementia. So the most common symptoms are apathy, depression, and agitation, wandering. Less common are psychosis and hallucinations and delusions, or violent or aggressive behavior. So these are observed in almost every patient. As you can see, the prevalence is very high. It's around 61 to 92%. And usually they have an unmet need which triggers these symptoms, because pain, hunger, thirst, or a need to urinate or defecate. And sometimes sundowning, that is towards the evening time, these symptoms are triggered. And because at this time the patients they just exhibit these behaviors because they're unable to communicate. That is the most common reason for these symptoms. So neuropsychiatric inventory is one of the instruments used to assess BPSD, and it is caregiver. It has to be administered to the caregiver, and it has 12 symptoms, and the caregiver, it's a semi-structured interview. The information is given by the caregiver. So interventions for BPSD, there are, firstly, it's always recommended to go to the start with non-pharmacological. And according to this recent paper, there are 4 categories of non-pharmacological interventions. The first one is a cognitive or emotion-oriented interventions like reminiscence therapy or simulated presence therapy and validation therapy. The second is sensory stimulation interventions like acupuncture or aromatherapy, light therapy, massage, touch, music therapy, and even TENS can be used. The third category is behavior management techniques, and the fourth is a psychosocial intervention such as animal-assisted therapy and exercise. So all these don't have much evidence, but they are it's advised first to use them and then go on to pharmacological if their symptoms do not improve. So most common class of drugs we use are antipsychotics, especially for agitation. So the typical antipsychotics are preferred over haloperidol, and there's a lot of evidence for risperidone, quetiapine, and olanzapine. Antidepressants are also helpful in treating agitations, and those depressants, the medications for choice are citalopram, escitalopram, and sertraline. Also, the drugs used for cognitive impairment can be used even for BPSD. And anticonvulsant mood stabilizers are very less commonly used, but can be used as an add-on. So carbamazepine, valproic acid, gabapentin, lamotrigine, and topiramate are used. And benzodiazepines are actually contraindicated, and they are should be used very cautiously, because it can also cause paradoxical worsening of symptoms or an excessive sedation. So we would use them very cautiously only when in a situation where the agitation is not relieved with antipsychotics. And lorazepam, if to be used, lorazepam is a drug of choice. Other drugs, there's a lot of papers for evidence for mirtazapine in dealing with agitation, but and it's used in practice also, but very limited evidence for it's under studies for prazosin and cannabinoids and treating symptoms of behavioral symptoms of dementia. This is a recent article which published an algorithm for the use of type of drugs for the different types of dementia. So you can go through this later. So the next symptom I want to talk about is delirium. So this is, it's very important to know about this because the features of confusion are present in both. So we need to know the difference between, try to understand if the patient is delirious or is showing features of dementia. So there are some classical differences, like the onset. It's acute in delirium and more insidious in dementia. The course is more progressive and over a longer duration in dementia. Patients have usually clearer conscience in dementia, and their attention is usually normal, but it only is impaired in the later stages. They're usually alert, and behavior is intact early. For this Alzheimer's type, the speech the patient will have problems in finding words, but he would try to communicate, and psychomotor changes are often normal, and reversibility is irreversible in dementia. In delirium, always a cause needs to be evaluated, and some of the causes are reversible. So the problem is that delirium can also coexist with dementia. So the most common trigger is hospitalization for delirium in dementia. This is a flow chart which you can go through later on. So the gist of it is to evaluate the cause of delirium and always start with the non-pharmacological measures and go ahead with pharmacological measures only when it doesn't work. Since they're a geriatric population, we need to be very cautious about the antipsychotics we use, and ECG must be done prior to administering antipsychotics. And the patients have to be monitored, and we have to make sure that the patient is safe and avoid any risks like has no risk of fall. And the next symptom I would go through is pain. So this is also very prevalent. Around 60 to 80% of patients with dementia have pain, and since most of them cannot talk, it is more difficult to assess pain. But there is a score which is widely used, the pain assessment in advanced dementia scale in clinical practice, to assess the severity of pain. So a recent article published says that again the non-pharmacological management is important prior to starting analgesics. So there are some recommended non-pharmacological management like music therapy, exercise, massage, heat and relaxation therapy, and human interaction and presence. So when it comes to pharmacological management, paracetamol is a drug of choice in this population, because the other drugs which like NSAIDs, opioids, and adjuvants have to be used very cautiously, because and only after a risk-benefit analysis. This is pain assessment in advanced dementia. The scale is there are 5 domains and a scale of 0 to 2. So the total score is from 0 to 10, with the higher scores indicating severe pain. So the next symptom, which is very important, is dysphagia, because this becomes a very, very big problem as the patients start forgetting how to swallow, and there's a lot of loss of coordination, the swallowing mechanism. So also along with that, there is a functional decline, difficulty with feeding, and cognitive decline. There's decreased appetite in advanced stages and a drive to eat. So this will further cause more weight loss in a patient, and this is actually one of the most distressing symptoms to families and caregivers. So there are numerous resources available online, and you can go through these tips later on, and they'll require a lot of proper nutritional assessment and the help of a dietitian in determining a diet for the patient. So in general, I'd just like to say that while feeding, you need a lot of patience, and you have to give the patient a lot of time while feeding. Hydration is very, very important, and also giving food which rich in fibers is also important so that the patients don't develop constipation. And small meals are the key in regular frequent intervals. That is what needs to be done while feeding these patients. And most of the guidelines mention that hand feeding is the best method in feeding patients with advanced disease. In them is oral tube versus tube feeding, but like I said, all the usual the societies for American Geriatric Society, Canadian Geriatric Society, and the American Board of Internal Medicine's Choosing Wisely campaign all recommend hand feeding over tube feeding, because though some people do feel that PEG or NGT would prolong life and prevent aspiration and improve malnutrition related sequelae like pressure sores, but actually a lot of studies which have compared show that it doesn't prolong survival. It doesn't help in improving the nutritional status or preventing pressure ulcers. And in addition, there will be problems like tube dislodgement, blockage or leakage, and requirement of physical or chemical restraints. So this would just worsen the situation later on. So ultimately, this decision lies with the patient's values and preferences, his advanced directives, and what the surrogate caregivers want. That has to be incorporated into the care plan. The other problem is infections and fever. So this is also again very common, and mostly respiratory tract infections are more common than urinary tract infections. So we have to be very careful in the later stages, because there is a very low threshold for sending investigations and starting antimicrobials. So this is a criteria which has been given by the Society for Healthcare Epidemiology of America for starting antibiotics in urinary tract infection, respiratory tract infection, skin infections, and any febrile episode. So the point of this criteria is to avoid antibiotic misuse and to prevent antibiotic resistance. Now, personal comfort measures is a very important part, because the caregivers are so involved in doing every chore for the patient. It is very important aspect of that we need to know some things about it. So one of the chores are bathing, which patient might feel scared and show some resistance and may be very uncomfortable. So we have to be very gentle and promote safety at all time and give the patient privacy and dignity. The next task is the feeding part, where patient might have pain due to dangers or any digestive problems or even halitosis. So this we have to be very careful about their oral hygiene and their dentures, and requires to be very gentle while cleaning the mouth. Then dressing, the patient might be forgetful about dressing or dress very untidily or shabbily. So it's important that we are we respect the person's dressing style, and also give them some simple and comfortable clothing, like avoids buttons, and instead of that we have velcros or zippers. And we have to support grooming routines. Also, footwear is an important aspect that we have, so that patients should be footwear to prevent falls. And toileting, again, very important, that they might have problems of incontinence and forgetfulness, that they have passed stools or urine. So we have to have a proper schedule for them. Their diet should have sufficient liquids and high fiber diet. So like I had earlier mentioned, be supportive and give them privacy and dignity. So there are a lot of resources available online and a lot of tips available which you can read later on. Now, along caregiver support is very, very important, as with this, the patient, along with the patient, the person taking care of the patient also suffers a lot, because this disease has a very, very long course. No day is same. Some days may be very challenging. Some days are maybe good and optimistic. But caregivers are always at a risk of developing burnout. So we need to support them by asking them to be patient, be aware of their body language. Sometimes their non-verbal cues might also trigger patients and may scare patients. So they have to be very calm, and they have to speak slowly and clearly, use short sentences. They might have to repeat sentences, but they have to do so in a very patient way. Then it's very hurtful sometimes that they might not remember important things of the past, and it's important to assure the caregivers that they don't do this on purpose to hurt them. It is a part of the disease. You always should maintain respect. We don't have to talk to them like they're children, even though it is dementia is actually like the patient becomes more baby-like. You have to maintain that the patient is an adult as much as possible. Support them when they want to take short breaks. They have to get some respite. And the local support group, there are in our country, we don't have such support groups system in most of the diseases, chronic diseases, but in the West it's very common that they have support groups for caregivers and dementia. So there are a lot of resources invested for caregiver support in the US and the UK. How do we play a role now? So in early stages, as a palliative care physician, we may help them in at least initiating the advanced directive and goals of care conversation, and treatment and assessment of symptoms, and caregiver assessment. In moderate stages where the behavioral symptoms develop, again, besides the earlier interventions, we also need to assess their home and help them in the caregiving at home. In the later stages, again, we have to revisit the goals of care and their advanced directives. The symptoms become more complicated, so we play a role in managing those symptoms. We have to help de-prescribe medications and use only what is useful for the patient. We can assist in the hospice referral as well as the end of life management. So advanced care planning is very, very integral part of dementia, and it is in continuing it is a dynamic process of reflection and discussion between patients and their relatives and healthcare professionals, which allows patients to communicate their values and treatment preferences that are important for their further care, and particularly for which these decisions play a very role later on during emergency and end of life situation. So there's a recent paper which was published, which gave around 32 recommendations for healthcare professionals in dementia while conducting an advanced care planning. So they have given these recommendations under 8 domains. I'll just give you a brief layout of the recommendations. Initiation of ACP has to be done at the earliest stage possible, and it should be initiated by the healthcare professional. And the evaluation of mental capacity, always we must assume that the patient has maximum mental capacity, but this mental capacity can also be fluctuating. So we need to keep that in mind, and we might have to hold these discussions more frequently when patient because of the fluctuation of the mental capacity. these ACP conversations have to be styled to the content, and the content should be comfortable for the patient. Patient should be able to understand and maximally participate in discussion. We have to guide the patient in formulating their care goals, and lay down specific situations and ask them what they would do. The role of the role of family is very important in dementia, because we need to evaluate their disease awareness and their preparedness to deal with complicated symptoms as the disease progresses. Then we have to document their wishes and preferences, and including information transfer. So this can be done always. It's better to document it in a written format, and it is not final. It is very important to convey that to them. What they decide now can always be revisited again and again, and changes can be made. During the end of life decision making, the healthcare professional should always recommend what is in the best interest of the patient versus what they planned. It must be carefully weighed. Then the last is the preconditions for optimal implementation. So here we need to train healthcare professionals and in communicating, and so that they are more confident in advanced care planning, and also it should be included in the policies of the institutions. So this is just for some knowledge that in our country, what is happening for dementia. So we don't have a national dementia policy in yet, but the Alzheimer's Related Disease Society of India has done a lot of remarkable work for this population, and they have published two important documents: the Dementia India Report in 2010 and the Dementia India Strategy Report, which is more recent in 2018, which gives more about the prevalence of dementia and how the burden is going to increase, and how how strategies need to be implemented at different levels of healthcare. But still, this is just a document. Not much of it has been actually practically implemented. And a lot of ministries are available, have provided schemes for these patients, which are enlisted over here. There is a national program for healthcare for the elderly, which has taken initiatives to train healthcare professionals for dementia, and also setting aside beds for patients with dementia. The Mental Healthcare Act of 2017 includes dementia, and it emphasizes on their right to access healthcare services, right to live with dignity and not be segregated from society. It also emphasizes that their right has to be protected. They have to be protected from cruel or any inhuman treatment in any health establishment. So this is just some trivia, some good news that Bangalore is features among the 30 global cities in the Dementia Innovation Readiness Index. So this is a list of cities which they have seen the preparedness based on 26 indicators, right from the diagnosis till the end of life management, how cities are prepared in managing symptoms of dementia. So this is a dementia trajectory. As you can see, it's a long course, and it is only a downward spiral and functional decline. So why this is important is that we need to understand how to prognosticate dementia, and for that, and also it would help us in end of life decision making when we know the end is near, and it could also prevent the use of any burdensome interventions in the last 90 days of life. It is also, prognostication is also important to determine any hospital eligibility. And because many physicians cite that it is because they are unable to prognosticate earlier, they are referred later to the hospices. So there are some scoring systems available. FAST is again the staging system for Alzheimer's is also used to prognosticate, as I had mentioned earlier. So once the patient reaches the 7th stage, it is advanced dementia, and there is a very old study which is says that beyond 7C, that is loss of ambulation, the median survival is 3.2 months, but it's not general. It can't be generalized to all patients. The other scores developed by Mitchell are mortality risk index score and advanced dementia prognostic tool. So there are a lot of there are scores of some criteria over here, and the sum of the scores determine the risk estimate of death within 6 months. So higher the score, more indicates higher risk of death. This was a recent meta-analysis, systematic review, which mentioned about the prognostic indicators of 6-month mortality, signs of suffering like screaming or in agitation as perceived by the attendant, hematology investigations like CBC if there's patient has sepsis or anemia or even low protein or cholesterol, speech and language problems. In demographics, they mentioned that older age, specifically about 85 years, male patients, married patients are more have poorer prognosis. Any unstable medical condition, loss of ambulation and motility, any functional or cognitive impairment, comorbidities like congestive heart failure or cancer, COPD, and increased risk on the relevant scale, whatever we use to prognosticate, and poor nutrition or nourishment and loss of appetite are also poor prognostic indicators. So in our country, we don't really have a hospice set up for only dementia patients. And whatever hospices we have are mostly for cancer. But abroad, we have the concept of old age homes in our country. Abroad, they have a lot of resources dedicated for dementia patients out of community health centers, and they have very strict hospice criteria for them. So again, the fast staging is an important parameter here. Once this patient reaches beyond 7th stage, but at the 7th stage, and also any of the medical condition, one of it which must be present, like aspiration pneumonia, pyelonephritis, septicemia, any decubitus ulcer, a recurrent fever or after treatment with antibiotics, or inability to maintain sufficient fluid calorie intake. So yeah, so with this I would like to conclude my presentation that the societal burden of dementia as a terminal illness is substantial and increasing, and patients with advanced dementia and their caregivers are faced with a range of physical and psychosocial needs. So we play a very important role in improving the patient's symptoms, lessen caregiver burden, and help ensure that treatment decisions are well informed and weighed in the context of patient, family, and caregiver goals and needs. So these are a lot of sites where you get plenty of resources, and also there is a helpline available for dementia patients, but I think it's available only during the daytime. And this is a blog where there's a lot of legal aspects of dementia are discussed for patients and also their caregivers. So thank you for your attention.
Thank you. Thank you very much, Arun. Are there any questions?
Yes, thank you. Thank you, Prarthna. One question for you.
Yes.
From Neetu. And the question is, what are the risk factors for dementia?
So risk factors of dementia is the most important is age. So age and also the environment, and but in the population wise, it's more common in the west side, and we don't exactly know any genetic. There's no insufficient evidence about the genetic causes of dementia, but age definitely, and it's more common in females also because they are a lot of epidemiological studies show that females live longer than males, so that is why those are things. But there are no proper risk factors like mentioned. It's just epidemiological basis. Next question.
Okay, thank you. No other question. Just there are comments like excellent presentation, good presentation, but there are no other questions. Thank you.
Okay, so Dr. Joyita, do you want to comment on her lecture, please?
Yeah, thank you, Prarthna, for an excellent talk and very comprehensive. We really appreciated all the resources that you enlisted. That is really helpful. It's just that I just wanted to answer that question about age. But then there is a familial variety variant of Alzheimer's dementia, so we need to think about that. And for the vascular dementia, it's of course the hypertension and the diabetes, those would be the risk factors. And because the road to dementia is very long, by the time we get the symptoms, the clinical symptoms, especially in mainly in Alzheimer's dementia, the process has gone on for at least begun 10 to 12 years before that. So whatever we are doing is actually just sort of symptom management and as a reaction. And of course, there are lots of studies targeting interventions, which some are working, some are not working. And a lot of work is being done identifying both the pathophysiology as well as then what is the best time to target the interventions. But thank you, Prarthna, for an excellent presentation. And we are aware of what dementia is such an important problem, and you brought it to notice and you highlighted all the important aspects of it. So thank you, Prarthna.
Thank you, ma'am.
Okay, thank you, Joyita. And thank you, Prarthna. I think this was a very well covered topic, Prarthna. You have
Thank you,
covered
ma'am.
so many things, including what is the status of their guidelines and in India. And very important topic for residents, because we keep on forgetting that there is what are the common differences between delirium and dementia, how stepwise how we will approach a patient who is having dementia. So I think you have covered all the aspects very well, and I'm sure that today everyone will, those who have heard carefully, will get benefited. Thanks a lot. So thank you very much, everyone. Please take care. Again, you have to take full precautions, because now there is a high alert of new strain of coronavirus. So please take care of yourself. Within a week, whole world has changed, and hopefully India will remain stable, and it will remain stable only when we will be very, very cautious. So please take care of yourselves, and we will see you next week, Monday at 6:30. Before 6:30, please join. And I request everyone, please don't join with your without naming your devices. And from next time onwards, we will not allow anyone who will not name their device. So please name your device and then join. Okay. Thank you very much. This is for safety purpose, and we have to remain safe. So please name your device before joining. Thanks a lot. Thank you, Prarthna. Thank you,
Thank you,
Arun.
ma'am.
Dr. Joyita, thank you very much. Arun, Nisha and Archana, thanks a lot.
Thank you, ma'am. Have a good day.
Bye. Bye.